Hi, and welcome to the Psych Health and Safety Podcast. My name is Jason Van Schie, and I'm one of the hosts of the show. The aim of the podcast is to rapidly increase the knowledge and application of psychological health and safety in workplaces worldwide. To help with this, we have regular guests from around the world who are leading the way in this important area. Before I introduce our guest and topic for today, however, allow me to introduce my co-host, Joelle Mitchell. How are you today, Joelle?
I rode a bike on the weekend.
Yeah, congratulations.
The last time I did that, I was about 15 years old. So, and it is just like riding a bike, as they say. It was, so my son's recently upgraded to a sort of big kids bike. So we thought I should get something so I can keep up with him instead of sort of just walking and then him having to wait for me every time he gets to an intersection. But we were looking at electric bikes. So you still have to pedal, but you can sort of choose the power and it helps you a little bit since it's been so very long since I've ridden a bike. But the person at the shop had the power on, I think, the medium or high setting when I first started out. So it was very, very wobbly. My husband was a little bit alarmed that I was going to come to some harm. So then she came and took the power off to start with, and then it was fine.
Yeah.
And then I could sort of, once I was up and going, adjust the power and that sort of thing. So yes, that was an interesting experience being an adult and sort of trying to remember how to ride a bike, but the muscle memory does kick in pretty quickly. So
I like the big claim you made yesterday, Jason. I've got a new bike. I'm going to ride into work.
That is a gross misrepresentation of how I said that.
And then you said it's an electric bike. I'm like, well, are you going to be riding it?
No, that's not how that conversation went at all. I said, I'm getting a bike so that I can go riding with my son. It's an electric bike. And you said, is that so that you can keep up with him? And I said, no, it's so that I can also potentially ride to work. So let's just be clear about how that conversation actually went.
Yeah, or you could just drive your car because it's probably the same amount of exercise, right? Because
no, it's not. You have to pedal. You can't just. It's not like a low powered motorbike. Like you actually have to pedal for the motor to start working.
Yeah. Okay.
Yeah, and the idea is that I would actually cycle. I wouldn't just coast along, but it's so that I'm not, completely exhausted and then unable to work for the day.
Okay.
While I'm
I'm going to be very surprised if I see you rock up in your Lycra after your bike ride to work in the morning.
All right. You heard it here, listeners.
Yeah. Maybe on a future podcast in 2025, we hear about the time that Joelle rode the bike
to work. Well, it's only 8 kilometers and it's mostly flat. So it's not actually that.
Yeah. I'm not hearing any excuses here.
That's what I'm saying.
Tune in, listeners.
I'm not offering you any excuses. I'm saying it's my intention.
We will find out.
We will. And I'll rub Jason's face in it right here on this podcast. Purely, if for no other reason than that you've publicly called me out, I'm absolutely going to ride that bike to work.
Yeah, it's motivational, right?
I didn't need you to motivate me, Jason.
Well, I think you do.
No.
I don't think it's going to happen. Anyway, look.
Unbelievable.
It's not a cycling podcast.
Unbelievable.
Let's introduce our guest because it's getting late for him.
Yeah.
He is. Okay. So he's Canadian based, hence the time zone difference and why it's later at night for him. International scientific consultant specializing in men's health, workplace stress, health and resilience, and human research ethics review. Over the last 30 years, he's worked across a wide variety of applied and basic research contexts, including military, first responder, and healthcare. He's an adjunct professor of psychology at Brock University and owner of the aptly named Donald McCreary Scientific Consulting. Welcome to the podcast, Dr. Don McCreary.
Thanks, everybody. It's great to be on the show.
Yeah, great to have you. Joelle and I are on LinkedIn a lot, and it appears that you may be challenging us for someone who's on LinkedIn quite a bit and really forwarding, I guess, the conversation regarding workplace mental health.
Yeah, there's a lot of snake oil out there, which really bothers me. So I'm a big, huge advocate of evidence-based practice and evidence-based science. And so I try and, dispel some of the myths that are out there whenever possible, make sure that how we're going forward is based on accurate evidence, not a single study. I want to see some multiple studies and a systematic review before I I make any kind of claims. But that kind of rankles some people, but I'm okay with that. And for the most part, I think the message is well liked. I get a lot of more people saying, "Yay, keep it up, keep it coming," than say, "Don, shut up." So
yeah, as I keep saying to Joelle, you can't be Switzerland on a social media platform. Otherwise, people don't engage and you don't really challenge people. So it's good to see people like yourself and Joelle who are willing to call out the BS when they see it. So.
Well, and Don, I think if anybody's rankled by claims that are backed by evidence or by challenging claims that have no evidence base, then they're probably the people who are trying to sell the snake oil in the first place. So they deserve to be rankled.
Indeed, they're either financially involved, or there's some ideological reasons why they like the snake oil better than the evidence. So you can't fight with either, really. You can just keep on trying to get the message out.
Yep, that's it. So, do you have any podcasts that you like to listen to?
Ooh, Joelle, that's a tough one. I tend to listen to podcasts. I listen to a lot of podcasts, but I do so in a way just to disconnect from what I do during the day. So I do not listen to any podcasts that are work related. They all tend to be something that I can just disconnect from my day-to-day life with. So I'm happy to talk about maybe my top three, just very briefly if you like.
Yeah, absolutely.
I think one of my first ones, I'm a huge fan of science fiction. And I got through my PhD by reading science fiction novels. This is back in the mid to late 80s. So there's a podcast out there called Imaginary Worlds, which I just love. The host brings together a lot of different topics in the area of science fiction, but also delves into fantasy, role-playing games, which I'm not a fan of, but then challenges the reader to really, or the listener actually, to embrace some of the critical and the problematic elements of the science fiction, and that's been fascinating for me. So another one I like is I love to listen to podcasts about how the built world influences human behavior. So I love the 99% Invisible podcast, out of California. It's kind of American centric, but they do try and expand out to a non-American audience every now and then. And they've had some amazing podcasts over the years. That's one I actually, as soon as it comes up on my feed, I listen to it right away. And I found a new one that's actually a co-production between the Australian Broadcasting Corporation and the Canadian Broadcasting Corporation, called Stuff the British Stole. And it's got 2 seasons, and it's really fascinating. You walk into a museum and you see a lot of stuff, and a lot of that stuff is stolen, because of colonization and imperialism and so on and so forth. So it's a fascinating overview in that. So that's how I like to decompress when I'm out walking or hiking or going on a long drive.
Yeah. No, that's good. A lot of our guests do sort of focus on professional podcasts, and then I like to probe a little bit further and say, well, what do you listen to for fun? So I'm glad that you shared with us just what you like to listen to for fun, because it's
all fun for me. Yeah,
absolutely.
Yeah, that one, what was that, the 99%
Invisible?
Yes. Yeah, that sounds interesting.
Mm.
Oh, that's been a favorite of mine for I want to say 8 to 10 years, but I may be misremembering, but they've been around for a long time. Yeah, and they're a weekly podcast, whereas the new one, like the Stuff the British Stole, that's a series. So you get about 6 or 7 episodes, and they go on hiatus for a little bit while they create new stuff, because a lot of travel involved, a lot of whereas the other ones, they tend to be more either weekly or bi-weekly.
Yeah, it's like revisionist history. There's not enough of those.
No, definitely not.
I love revisionist history. That's fantastic. Yeah. Or the other one, Tim Harford's,
Cautionary Tales.
Cautionary Tales. I love that
one. Yeah, that's one of my favorites as well.
Yeah.
Yes. Educational and entertaining.
Yes.
So let's can you give us a bit of a summary of your professional career, Don?
Oh, that song by the Beatles, that phrase, "a long and winding road"? Yeah, or better yet, that graphic, where it's like, this is how people think I went through my career straight line, when in reality, it's just all over the place.
It's an enormous, messy tangle of squiggles.
Yeah, I hear you. I did my PhD in the mid to late 80s in Canterbury, England, in the psychology of gender, hence the expertise in men's health. But after graduating and coming back to Canada and entering the workforce, gender wasn't really a popular topic. It's not something I could have gotten grant money for, so I couldn't be an academic. There weren't a lot of people in the non-academic world who were interested in gender, especially gender and health, which is what I was interested in. So I kind of retooled myself into the area of what we call then stress and coping. So, what is stress? What is the negative outcome of stress, and how do we cope with it effectively? And eventually that evolved into more of a focus on workplace stress, health, and well-being. So that started probably in the mid-90s, and I've been working in that area ever since. And I've worked in provincial government, but I also spent 15 years working for the Canadian Department of National Defence, nominally studying psychological resilience in military personnel and first responders. But it ended up getting a lot broader, than that focus as well. So yeah, it was a fun time, working for national defense. But I left in 2016, and I've been consulting, ever since.
And seems to have sort of, I guess where you're at now seems to have looped back into that, the gender and health stuff that you did at the very beginning of your career, which is nice.
It is. I actually get a lot more consulting with the workplace stress and health, element, but I've done a lot of volunteer work with the Movember Foundation over the past almost 10 years. And so I've been able to, weave in still that interest. I'll always maintain my focus on men's health. And I chaired a subcommittee of the board of directors called their Global Men's Health Advisory Committee, for a number of years. And in 2019, I wrote a report for them on, the effectiveness of mental health prevention and suicide prevention and early intervention, programs in veterans and first responders, which we'll talk about later on. And so right now I'm actually helping the some grantees that came out of a grant round that resulted from the report I wrote to try and maximize the gendered lens element to their program. So that way I'm able to combine both my expertise in men's health and gender, but also workplace stress and well-being.
It's nice when a plan comes together.
It's not too often I get to merge and blend my two interests. So I'll take it when I can get it. That's for sure.
Yeah, it must be incredibly rewarding to be able to combine those things in that way.
It is, because I've had to keep them separate for a number of years. So for a number of years, the workplace mental health stuff was what I did during the day, and the gender stuff was what I did evenings, weekends, and holidays. But now I get to merge them, a little bit more frequently, for what I do for a living. That's great.
Mm.
Yeah, well, we're recording this episode in November, and this is a very busy month for Movember. So many people will know of Movember, the International Men's Health Charity. I think they focused initially on prostate cancer, didn't they? But have really extended into all sorts of men's health issues, including mental health.
Yes, I think they started off in prostate and testicular cancer. And then I think it was around 2006, 2007 in Australia, they started expanding out to the mental health field, and really started expanding in that area in a lot more of their markets in 2012, which is how I got involved. They started pushing into Canada. They wanted to improve some workplace mental health initiatives, create some, or in Canada. And they reached out to a group of us in Canada who were interested in men's health more broadly. And I've been working with them ever since. It's been fantastic. It's been very rewarding.
Yeah, so they've obviously engaged you formally in some research. What was the focus of that research, first of all?
I think the focus of the research we're talking about is the project I did for them. I did a scoping review for them in 2019. They came to me in 2019 and said, basically what they wanted to do was they wanted to identify the most effective mental health prevention program or programs actually that were used in the veteran and first responder space in Australia, New Zealand, Canada, Ireland, and England. And so what they did is they asked me to review the literature, do a scoping review, identify the best, the most effective programs. And then what they were going to do was then find some people to roll those programs out so that more veterans and first responders actually had access to them. But what ended up happening was my report showed that none of the programs were really effective. And that led them down a really different path. So what ended up happening, as a result of my my scoping review, was that they said, okay, well, there's nothing out there works. We need to find which programs have the most promise, and then maybe help people tweak them in a manner that does work, and then evaluate them so that we can demonstrate how effective they really are before we roll them out to these populations. So they don't want to roll out something that's ineffective. And that process really has been underway, since that report.
Yeah, that's really interesting. I did read an article recently about Martin Seligman's US military resilience program. And that was really bought into in a big way. I mean, to the tune of tens of millions, if not hundreds of millions of dollars, with little evidence up front about the effectiveness.
No, it was all based on ideas that came from his program, which I guess one could say they were evidence-based in that context. But once you take those ideas out of that context and put them into a completely different context, they no longer become evidence-based. They become evidence-informed. And that's when you need to actually determine what the effectiveness of these ideas you've taken from point A and you've applied them in context B. They still now need to be demonstrated to be effective in context B, but that was not done for quite a while. And when it was done, there really wasn't any measure of effectiveness. Any effectiveness. They tried to measure it, but they didn't find anything.
Yeah, that's the interesting thing, right? Because I remember reading his book Flourish, and he talks about this, and he was assuming they would say, oh yeah, let's start off with the pilot. And research the effectiveness. So it wasn't Seligman's fault, I don't think.
No.
The military really just rushed and said, we want to deploy this at scale without looking at, researching whether it is effective beforehand.
Well, and the Canadian Armed Forces did something really very similar. Back in I think it was 2004 when Canada started, first went into Afghanistan. I got a call to be part of a Canadian Armed Forces mental health advisory commission. Their role was really to oversee the development of mental health education training, for those troops who were deploying overseas, with the goal of preventing, mental health symptoms further on down the line. And so our oversight committee, we oversaw the development of a program called the Road to Mental Readiness. And ironically, I was on that committee as the evaluation consultant, but the program never got evaluated until way after it was since given to the Mental Health Commission of Canada to roll out to first responders across Canada. It was touted as an evidence-based program, but it wasn't evidence-based. It was only evidence-informed. Nobody had ever tested the effectiveness of the program because everybody was so busy giving the program. There were no resources allocated to evaluating its effectiveness. And when the evaluations did start coming in, they were showing no effects whatsoever. And what do you do at that point when you have so many people invested and you've spent hundreds of thousands, if not millions of dollars training people in a program that is not evidence-based, it doesn't work, it's evidence-informed at most. And, what do you do?
I think this is a really important point for our listeners, is that this issue of generalisability, and this is really why you need, if you're evaluating programs and you're thinking about implementing something, you really need somebody with a good level of social science literacy to be able to actually assess the papers that are they're supporting or claiming to support the intervention, and actually looking for evidence of generalizability to your particular context. And this is it's a really nuanced issue, but it's so critical because, I've seen it happen all the time where, a particular organization will develop something bespoke for them and it works really, really well for them. and then a competing company will poach the project lead who developed the whole thing and say, we want you to do that here, and they do exactly the same thing there, and it completely fails. And it's because they haven't considered context. They haven't considered what's different about us than our competitor that we might need to tweak or whatever it might be. So I think, you do really need to understand what generalizability is and think about that very carefully when you're evaluating any intervention.
I think there's another problem inherent in at least the mental health prevention sphere, and that is that organizations will build something based on bias. They think that this will work. They have this intuition that this will work. So they build it and they implement it, but then they don't evaluate it. They don't assess whether or not it does what it says it's supposed to do. And there are so many projects or so many programs that I've heard about through interviewing and talking with subject matter experts in the first responder community that are out there but have never been validated. Or if they have been validated, the validation results are behind a wall that I can't see, which suggests to me that they probably don't work if they're not being made publicly available. Because I would say that if you create a program that works for your people, tell everybody about it so that they can try it and see whether it works on theirs. And if not, then we can find out why, and we can advance the science, and we can advance the application and the prevention of poor mental health in those who are especially at high risk. But if you are building the programs and you're not releasing the evidence, then even if it doesn't work, especially if it doesn't work, that's helpful information.
Yeah, absolutely. I think that's where the All Trials campaign is really showing a lot of promise, and I think it's such an important thing that needed to happen.
I agree. Yeah, and part of the problem I think there is a lot of social scientists. They think of All Trials as more of a clinical pharmaceutical tool. Something very similar to that has been popping up in science, in social science, in occupational health psychology, and other aspects of psychology, and that is registered reports, where you send in an outline of what it is you're going to do. It gets peer reviewed, and then you go and do it. And then the journal is now obligated to publish your results, positive or negative. So your methodology gets critiqued right up front. And that's fantastic, because oftentimes when we take a look at the systematic reviews of the effectiveness of these types of programs, when you look at the quality of the studies, they're very poor. So what ends up happening is that these pre-registered reports, they end up beefing up the methodology at the very beginning before they go out and actually do it, which can only have a positive impact. And then the journal will publish negative or positive findings, which is, I think,
and it's it seems like such a better use of everybody's time to peer review the proposed methodology first, rather than after the whole thing's done and the money's spent, to come in and say, well, this could have been better and this wasn't great, and we're not going to publish because we think your methodology was flawed. Well, there goes however many years of those researers' lives, and all of the participants and the funding and all of that. So I think that let's do some proactive peer review before the methodology even goes underway.
I think I really want to see much more of that happening, and that would be a great way, especially when you consider one of the barriers to going out and doing actual workplace mental health prevention research is getting the involvement of the organizations themselves. And you want to be able to maximize their time and the efficiency that which you interact with the organization. You want to minimize the burden on the organization in order to get good data. So if you can go in with a plan, say this is the project that's been pre-approved, we're good to go, and then work with them to minimize the burden on their staff, then I think that's fantastic.
Yeah, I think a point that was well made by, I forget who it was now, I think it was one of our other guests recently. Every time it was Kevin Teo, especially with mental health, every time you do an intervention, you're taking effort from the population who are potentially already under stress. So you're actually adding to their stress, you're adding to their load. So you actually, from an ethical perspective, need to think about, is this intervention actually worth the effort that it's going to require of the participants in terms of the benefit that it's likely to deliver.
But I think we also need to think about evaluation as well.
Yeah.
Like, yeah, it's great doing an intervention, but if people have to complete an hour's worth of surveys or whatever,
And there lies the interesting conundrum that we face, and that is that for some of the measures, like if we want to assess, let's use depression and anxiety as an example, we have short, valid measures of depression and anxiety. But what happens if we want to measure job satisfaction? A simple question like how satisfied are you with your job doesn't really get at it. You actually want to be able to measure job satisfaction in a number of different aspects of the job and be able to pool them all together. And sometimes in order to do that, to get a valid, broad view of satisfaction with one's job or engagement with one's job, then you need a larger measure to measure it reliably and in a valid way. And so by the time you end up having, if you've got an intervention that has multiple outcomes, associated with it, then you have these multiple tools, and they're necessary, but they add up over time. And you're right. So how do you balance out the wanting to have the most impact, the most broad impact for your intervention, but then minimize the evaluation burden on the participant? So sometimes you have to go in and say, well, we're going to try for less up front because we don't want to overburden the participants, and we'll add on to it later on, maybe. I don't know.
Yeah, this comes up in burnout research I've seen recently as well. Like, often when you're looking at measuring burnout, people go, well, we're going to reduce the load on people and we're just going to look at the emotional exhaustion component.
Yeah.
But then are we actually then covering what burnout is? And so we're not really looking at the reduced self-efficacy and the cynicism that is associated with burnout.
I just gave a webinar last week on burnout for the Canadian Institute for Public Safety Research and Treatment. And I thought one of the biggest pushbacks I was going to get when I said burnout isn't a diagnosable disorder, it's a set of symptoms about what I would really call a toxic workplace. And because burnout is really all about the exhaustion, cynicism, and lack of professional efficacy elements. And I thought I was going to get pushback because so many people, when they think of burnout, they just think of that exhaustion element, but I didn't get any, and it was really fantastic to see people understanding that burnout is much broader than it really is.
Well, that was kind of a tangent, a really good tangent.
We did. I took us on a side quest.
Hey, I'm happy to go on a tangent, so.
Yeah.
All my conversations are tangents.
It's nice to be able to have a little bit of a nerd out about research sometimes, isn't it?
Oh.
Yeah. Well, I wanted to bring up the whole Carol Dweck thing, but we probably don't have time for it, like the generalisability and whatnot. So.
Oh yeah, I can talk for hours on generalisability. Don't get me going on fidelity. Program fidelity. Yes.
Okay. But you know what? We're actually on our first point on the agenda.
We are,
and we're talking about the Movember research, which looked at the effectiveness of workplace mental health interventions. And basically you identified that there wasn't really good evidence to support any of the interventions that are available. So what conclusions were you able to draw from that research?
Well, the report I put together actually, it started off talking about psychological safety in the workplace and the advent of standards. This was done pre-ISO, so but I wanted to use that to set the stage to say, hey, look, it's important to have psychological standards for psychological safety in the workplace. But then I did an overview of the effectiveness of programs to prevent mental health or mental ill health in the general workforce before getting into veterans and first responders. And I did that because it was important to have a comparison group. If you want to know what's going on in veterans and first responders, you have to know what's going on in the general workforce as well. So let me talk, if you don't mind, I'll talk a little bit about that first before I get into sort of the crux of the main purpose behind the report. So there have been a few systematic reviews and meta-analysis, and you'll find I'm a big proponent of systematic reviews and meta-analysis. Single studies really don't tell you anything. Even if it's an RCT, it doesn't really tell you anything. It tells you, hey, we've got an idea that this is how things might work. A couple of more studies after that gives you an idea of a trend. You really need to have several studies in multiple different contexts in order to determine whether or not something works and it's generalizable and so on and so forth. So there have been a few meta-analyses. that are out there, systematic reviews that have been looking at the effectiveness of general workplace intervention programs. And they basically showed if there were any effects, they were small, and those small effects disappeared after 3 months. So, in other words, what you end up getting is a quick bump right off the bat, but all the effects really kind of disappear very quickly. So there was some of these meta-analyses, they actually looked at different types of programming. And what they find is that one-on-one training is better than, sort of the death by PowerPoint, train the trainer types of models, et cetera, et cetera. So the one-on-one kind of training is the most effective, and but it's not very cost effective. So it gives you the biggest effects, in terms of preventing mental health, poor mental health down the line, but it's very, very expensive. And the other thing you found is that a lot of these mental health prevention programs are really all about skills building. So they want to teach you about breathing. They want to teach you about the SMART, way of, of reading, the system. They want to, they're going to give you coping strategies and skills. But what they do is they don't actually give you any supervision or time to learn them. They actually they talk about them. They maybe give you 1 or 2 chances to try them. It's death by PowerPoint. So then they move on to the next thing. So they give you 2 minutes. And what these systematic reviews have found is that programs that actually give supervision to skills development actually work better. But programs that don't give you any supervision don't really work at all. And so, unfortunately, the vast majority of programs, they don't give any supervision or very minimal supervision to skills. And the other thing is that skills atrophy over time. So unfortunately, what ends up happening is some organizations, when they do this mental health prevention training, they're doing it as a tick box episode, type of thing. They come in and they say, oh yeah, no, we're going to do it. You're going to get it once and you're now covered. But think of the medical focused, first aid training. That's only good for 2 years. And what the research shows there is that unless you use the skills on a regular basis, you start losing your skills after 3 months. After 6 months, you're kind of useless, but you can probably still get something done. But after 2 years, you definitely need, to be recertified. Well, what we do know is that these skills atrophy over time. So they maybe only last 3 months. So we have to find ways of building up, and maintaining that, the effects over time. And then we have to build in some kind of booster, if you will. And so that's kind of, what we found, or what I found anyway, in sort of the general, literature. But the other thing I found is that when evaluation happened, it typically used a very weak or poor method to assess the outcome. So a lot of times it used either a very simple pre-post design, not often a pre-post-post. There may not have been a control group. Just we're going to look at the changes in this one group over time with no control group. Or sometimes what it does, it just uses purely cross-sectional types of compare. We're going to give this group at this site, this intervention, but we're not going to give it to that group over there, but it's not randomized. It's just like different site A versus site B. So what we end up finding is that studies that use weak types of evaluation methods, like, not a really good RCT, actually find elevated significance and elevated effect sizes in their program evaluation compared to an RCT or a good quality RCT. So they come out thinking or looking better, but they're really looking better is really just a function of their poor methodology. And I think I just want to sort of, say I'm kind of negative here about, saying all programs, but there was one program that is looking fairly decent, but we need to improve the quality of the research on it. And that's mindfulness meditation. So the evidence for mindfulness meditation as a workplace mental health prevention type of program is pretty good. But again, how much of the pretty good is a function of the poor methodology, and how much of it is a function of the program itself? We don't quite know that yet. But if I'm going to talk to anybody, if I'm going to recommend any type of program based on the current evidence, I'm going to recommend mindfulness.
Yeah, we've actually just done a recent review of mindfulness meditation, led by Dr. Alicia Pappas in our team. And there's some really wishy-washy stuff out there. It's hard to even call it mindfulness. So when we say mindfulness, there's a vast array of quality, I guess, when you're talking about that.
And one of the big problems is whenever you start taking something like mindfulness, which is, in essence, it is sort of a manualized prevention program in the sense that there's a certain way you're supposed to teach it and the way you go. But what ends up happening is workplaces don't want to, the first thing they ask is, can you cut down the time involvement? So with mindfulness, the first thing they teach you is a 45-minute body scan, which you're supposed to do daily, or at least a few times a week before the next type of session. But people in the workplace don't want to spend 45 minutes a day or 45 minutes 2, 3, 4 times a week on that. They want to cut down. And so what people end up finding is there's a push to water down the quality of the intervention. And that may lead to some of the wishy-washy, and the inability to compare across programs because how watered down was your program versus the other program?
Yeah, no, there's a lot to be said about fidelity. We're not going to get on that topic, otherwise we'll really get you going. But yes, no, it does really need to be content that's developed by people who actually understand the techniques around mindfulness and not just giving you a relaxing script to meditate to.
Yeah, and also I think one of the key elements there is sometimes what they'll do is they'll teach you, maybe in a workplace setting, they'll teach you something, but they won't actually work with you to build the skill, to build the way you do in a regular meeting, a mindfulness training course. You end up the instructor will end up working with you to reinforce the skill that you're being trained in over time. And that doesn't necessarily, happen in a workplace setting as much.
And I guess the time to actually implement that during your workday as well. Am I allowed to book out half an hour in my calendar? And is there a quiet room that I can also book out and go and do my half-hour meditation during my workday? Or is that something that I'm expected to do in my own time?
Yeah, can I use that mindfulness pod?
Yeah.
Yep. And then you always get, because it's a workplace setting and somebody else is paying for it, and if you're doing it during work time, you don't necessarily get the same level of investment from the student. To give you an example, I once took a mindfulness training course with my previous employer, and it was the standard mindfulness course with the 45-minute body scan, and the person sitting next to me didn't do it because they felt their time was more important doing research, than it was taking care of themselves. So you have to have that buy-in, from the individual. And oftentimes, when you end up doing something in the workplace, there's not the same level of motivation, to do it. Sometimes it just may be something that they may want to be seen doing, by their supervisor to show that they're quote unquote managing their mental health. But it is motivation is a key factor. Self-selection into the program, could be a key issue as well.
Yeah, interestingly, we had Dr. Georgie Tomer on recently, and she was talking about burnout prevention, and what she covers is very much work design, so dealing with, I guess, the root cause of work-related stress, but also supplementing that with mindfulness meditation as well. So, it seems to be, we often talk about that shared responsibility for workplace mental health. So if we can teach individual skills as well as improve the working conditions, then we're much better placed to improve mental health outcomes.
Now, I want to say that I'm a big fan of mindfulness. I took a stress management course back in 2004, 2005. And I don't want to be over dramatic here, but I think it saved my life. I did it every day. I did the breathing or the visualization exercises. I did one of them every day for 7 years. And I think it really did a wonderful thing. And then when I fell off the wagon, I could actually feel the stress coming back in my body, and I haven't been able to get back on the meditation, wagon since. So I wish I could, but I found other ways to manage my mental health, hence my love of hiking.
Yep. Yeah, that's a great way to do it.
And that's, I suppose, there's passive mindfulness and there's active mindfulness. And I think, a lot of those things like hiking, or, my husband, although we don't live in an area where there's snow, he does like to go on snowboarding holidays, and he finds that that's a really good way of, because you're so focused on what your body is doing in the moment, so you're not, I guess it's a form of mindfulness, but it's a active rather than passive mindfulness. Yeah.
And there actually is a lot of research out there showing that being out, and walking in nature is actually, very stress reducing. I don't know what the quality of that evidence is. I don't know how long the effects last, but there are enough studies for at least 1 or 2 systematic reviews, in the area. So, I was hiking a trail a couple of weeks ago that was put together by some local bikers, mountain biking, community, and the trail was called Therapy. And I thought it really got the reason I hike. So that was good.
Yeah, it's interesting. Dr. Stephen Alardi from Kansas University. I'm not sure if you've seen his TLC program, the Therapeutic Lifestyle Change for Depression. He's got 6 different elements, and one of them is getting out to nature, and he talks about the evidence base behind getting out to nature and the impacts that it has on our mood. So
I think there's so much that that really needs to kind of just go forward in the workplace. And anyway, sorry, I kind of lost my train of thought there.
Yeah,
so
no, I think
I'm happy to have you lead me on this.
It's up to Joelle. I think we're still talking about the Movember research.
So you did the general sort of the general population, and then you compared that to the first responders and veterans.
Exactly. So what I found was that within the first responder community and the veteran community, there really weren't a lot of studies, where they implemented, mental health reduction or prevention programs, within those communities. So there were 1 or 2 individual studies within the first responder community, and they really didn't find a lot, that was consistent. And there were a few studies that were out there in the veteran space as well, but again, not a lot out there. So there really is a lot of evidence lacking in terms of what works in terms of prevention, in the veteran and first responder space. But there are a couple of really interesting things that I did notice. And one was that within the veteran space, there's a function, sometimes adaptation to life after service can be more problematic for some veterans than others. So what the research is suggesting is that those who leave service because of medical conditions tend to have a rougher transition than those who leave because they're retired, or they leave early because they don't like their, the job, in the military. So they move back, they move out of the military into the community. So, but part of the people, when they leave, when they have medical conditions, oftentimes there's a mental health hit along with chronic health conditions. So a lot of times when people leave because, say, musculoskeletal injuries or other kind of work-related, health injuries, there is often a comorbidity of depression or anxiety that goes with that. So what are we experiencing? So the transition from military to civilian life can exacerbate some of those mental health symptoms. But one of the biggest issues for veterans anyway around transition, and that can cause a lot of poor mental health during the transition process, is whether or not they have any ties to their local community before they leave. Some military people, their only ties are with fellow military members. But some people actually get out and get involved in their communities that they're living in, even while they are serving. And we find that those people actually have a better transition because they're not leaving just a job, and they're leaving just a job basically, whereas other people are leaving a job and a family all at the same time. And so it's much more stressful, for them. So yeah, it's an interesting area, but again, there's really not a lot of systematic research, on preventing mental health symptoms in veterans or first responders. I think, as we was talking about earlier, the biggest issue was like a lot of Martin Seligman's work coming out of the U.S., military, and the road to mental readiness, which I talked about earlier. But again, none of that really works. So,
so you I guess you conducted this research. You found that there just wasn't any evidence of efficacy in this population. What's happened? Have researchers responded to that finding and gone forth and conducted studies?
Well, what's happened since 2019? Well, first off, 2019, about when COVID came about, but that didn't stop people from still publishing. And there have been a couple new systematic reviews that have come out, especially in the area of early intervention work as opposed to prevention work. Because in first responders, what you end up getting is there's the mental health prevention element, but then there's also what do you do post-trauma exposure, for first responders. That's that early intervention approach. So there's the critical incident stress management and there's the peer support. Those are the two main, ways that first responder groups tend to address, work-related trauma. And there were a couple systematic reviews. There were a couple of narrative reviews, and these are just people putting together and summarizing the literature. And they were suggesting that CISM, critical incident stress management, and peer support do not prevent future, mental health, the onset of more mental health symptoms after trauma exposure. And so since, and I reported that in my report. And since then, there have been a couple of systematic reviews and meta-analyses that have come out kind of still supporting, that notion more rigorously, with the science. In fact, it's gotten so bad for critical incident stress management that the UK National Institutes for Clinical Excellence actually say that CISM should never be used as a way of preventing, the onset of PTSD after trauma exposure. But it's still one of the most popular forms of intervention that are out there. It's being used by everybody.
I recall incorrectly that there was some evidence to indicate that it was actually harmful.
Back in the early mid-aughts, yes. So the Mitchell model, there was part of the Mitchell model that was shown to be harmful around, that could re-trigger somebody or re-traumatize somebody by talking about symptoms in a group. And I think that's been addressed. So the model we're seeing now has addressed those initial concerns, but we're still not finding any effects.
So it doesn't actively create harm, but it doesn't help either.
No. The new model, from what I understand, doesn't
would we call that harm, progress?
but doesn't help either. Well, yeah. What you end up when the UK National Institutes for Clinical Excellence came out and said, no, don't use this. There's no evidence for it. Stop it. A large group of first responders and the British Psychological Society wrote a position paper saying it may not have an impact on mental health, but it may be helpful in other ways because it provides social connection. It provides one-on-one interaction. So there may be other benefits that are non-mental health related. I don't know. I find that doesn't really sit well with me, but
put on a barbecue. So
is it more of a matter of being seen to be doing something? And if there's no other alternatives available, people have been through a trauma, and what are we doing as their employer? Nothing.
Yeah.
What did Tony LaMontagne say about that? He said it's criminal, he reckons, like if you are doing basically just individual level interventions and not considering the role of work. Because then if it fails, then the people feel, it was my fault. I didn't apply the skill correctly,
Yeah. That sounds like something Tony would say. Yep.
He was very fired up when we had him on the podcast recently.
Yes. Well, if he held back, I certainly didn't notice. So has there been any movement forward on your findings, maybe sort of from Movember's perspective or other areas?
Yeah. So actually, before I get on that, let me just talk a little bit about some of my sort of general conclusions, because those conclusions really feed into what's happened next. one of the first conclusions I said is, hey, there's too much focus on PTSD for veterans and first responders. No one's really looking at the non-traumatic workplace stressors. And these are the standard kind of workplace stressors that are common in the general workforce, but they're also there in the veteran and first responder workforce as well. And some research that's come out of Canada suggests that these non-traumatic stressors are actually more strongly associated with poor mental health than trauma exposure is. So the point being there is that you think trauma exposure is the biggest problem, but really it's the organizational stressors or the non-traumatic operational stressors, things that come from, say, the job demand, control model, or the job demand resources model, that kind of thing. And so there's that element, and I think that that's something that that's kind of been built into some of the future work. There's also been, we talked about the misuse of the phrase evidence-based. And I'd like to see less use of evidence-based and more evidence-informed, or at least more education around the distinction between the two. And again, we talked about the poor evidence quality, but one of the biggest issues, especially from a Movember sense, is there's a lack of a gendered lens to these types of prevention programs. So veterans and first responders are mostly male. Within the ambulance community in a lot of these countries, they are more 50-50, a good gender balance now, but the majority of the senior management are still male, and the workplace culture is a very masculinist culture. So we are still dealing with, very much a men's health, issue in some respects. And the programs were gender blind coming in. So they really didn't take into the fact that men may approach these types of programs differently. They may interact with these programs differently. There may be no reinforcement for actually, engaging in the tools or using the tools that they're trying to get these people to teach. So there needs to be a more of a gendered approach that basically adopts more of a positive psychology lens, promoting these things, these types of skills or interventions, in a way that speaks to men and enhances their likelihood of sticking with the program and engaging with what it is you're trying to teach them. So based on all of that, Movember came back and said, wow, this is not something that we thought we thought we were going to get Don to tell us which programs work best, but instead he's told us nothing really works. So in 2020, they issued 2 requests for proposals for researchers to come back to them with programs that they think are promising, but they don't have any evidence for, and they want to actually test the evidence. They wanted these programs to be have to apply a gendered lens, so to maximize them for men. They wanted them to be evaluated effectively, so they brought in a third-party evaluation team, to come in and help these people do this. And and so they ended up having these 2 requests for proposals. We had a grant review round this year, and they recently announced that there are 15 proposals that they're funding over the next 2 years in 8 countries. So myself, I'm working with a colleague, Steve Robertson, in the UK to work with the teams to maximize the gender lens element. So I think there hopefully, over the next 2 years, these teams will be able to at least tell us a little bit more about what works and what doesn't. I'm hopeful that it does work, but but science is really all about finding what doesn't work too.
Well, I guess that's good news in that there's some proactive response to your conclusions, and that that Movember is willing to actually say, right, well, this is a problem, and we're going to fund people to explore whether there are solutions currently available to this problem. Exactly.
Now, one of the key elements of the call was basically saying that we know that one of the biggest causes of this are non-traumatic workplace stressors, and there are organizational factors that are the biggest cause of these things. But unfortunately, only one of the funded programs is actually looking at organizational culture and trying to change organizational structure. A lot of them are still focused on the individual. That seems to be the current zeitgeist. I would have liked to have seen more programs, trying to change culture, but I don't think we're quite there yet. But I'm so happy still to see the one that is working. At least one of them is working on changing culture.
Yeah, it's it's much easier, isn't it, to measure change at an individual level, and to look at outcomes at an individual level. And I think that fundamentally underpins why there's so much research focused on mental health at an individual level. And yeah, it's looking at organizational factors and looking at organizational culture. When you're then looking at, can we actually determine a causal relationship here, it becomes much more complex and much more difficult to make any of those sort of causal claims.
Yeah, definitely. And we are doing some pre-post. There are some groups, there's some projects that actually have control groups built in. So there's some, trying to maximize the quality of the study to be able to make as many causal statements as possible. And who knows? I'm actually kind of hopeful that some of the projects may be able to indirectly influence organizational culture. Just by the fact that it's happening, by the fact that it's being funded by an external organization, that there's interest and that there's awareness that that individuals don't work in a vacuum, and that they are influenced by the way the culture supports things like overwork and lack of job control and lack of support and social support within the work context, and reduction of resources. The phrase "do more with less" is permanently infused in my brain, and I get anger every time I hear it. So,
and I suppose the other positive there is that if even if it's only one study, if it does have a really good methodology, then that shows other researchers that here's a methodology that you can now use to conduct research in this way. So that's a positive step as well.
Exactly. But again, I would argue, here's the methodology that you can use that appears to work, but please validate it in your context.
Yeah, absolutely.
And that can be a problem, because as you were saying earlier, Joelle, a lot of organizations, they don't have the skill to effectively assess these types of prevention programs, to separate out the BS from the actual scientific evidence. And at the same time, a lot of them don't have the expertise to actually assess the efficacy or the effectiveness of a program that is being implemented. Oftentimes they'll just use satisfaction with the program as a proxy, and as we know, satisfaction has zero correlation with whether or not the program works. It actually is correlated with whether or not people stay for the entire length of the program, but they got to like it if they're going to stay, but it doesn't really have any impact on whether it works for the people who do stay.
Yeah, a couple of things you mentioned there, Don, that I just wanted to point out is one regarding this fascination with PTSD in first responders and veterans, whereas it's often the normal everyday organizational factors that are contributing to poor mental health outcomes. And that's something that has been mentioned. I think Carla Kapanicki was one of the first to mention it very early on in the podcast.
Yeah, we've had a few. So Nicholas Wisen as well was talking about it. So we've had a few making that same comment. Dia Day as well, probably.
Yeah. Nicholas you get along well with. He's from Sweden, and he's done a lot of work in military psychology. So, but it seems if you were to do a desktop review, this would be a limitation, because you would go, well, as an industry, we need to be worried about PTSD, and you're not really worried about your factors and not thinking about your context. And I think that's why the first content clause of ISO 45003 is understand your organization in its context, which is an important step and one that is often skipped, I think, when people want to just get straight into the fun bits.
Yeah, and I think it's sort of the consistent message that we've heard from all of these guests is that people self-select into those roles knowing that they're going to be exposed to these types of hazards. So they know that they're going to witness trauma. They know that they're going to be, listening to people, sharing the worst experiences in their lives, all of these types of things. So they go in expecting that and being prepared for that. But what they maybe don't expect is that they've just got a real jerk for a boss, and the bureaucracy is just unbelievably complex and difficult to get anything done. And there's no real career progression, and I have to work all of this extra overtime without pay, and all of those, the minutiae organizational life is the thing that gets them.
Yeah. Well, just to kind of bring it back to Australia, one of the reports I read during when I was reading up for my report came from Phoenix, in Australia, and they did a review for the Australian National Police, and basically they wanted to know, how do we manage, workplace stress, kind of thing, and basically they came in and said you need to actually address the structural elements and the non-traumatic elements, in the workplace, and that would be your biggest bang for your buck. And they actually came back with evidence. They used two questionnaires that I created about 15 years ago called the Operational Police Stress Questionnaire and the Organizational Police Stress Questionnaire. So they measure non-traumatic operational and organizational stressors in police, but they've been used more broadly for fire, ambulance, and other public safety groups as well. And they showed how high these stressors were. And unfortunately, the ANP came back with, let's bring in road to mental readiness, and instead of addressing any of the structural elements, So, but yeah, it's a problem.
Yeah, and that measuring, successfulness of interventions in your organization when you bring something in, I think that's something where, again, I think the majority, maybe at least half of our listenership is probably from the health and safety profession. And I think that's something that they are really qualified to do, or this risk management stuff. We identify hazards, we assess risk, we control risk, and then we monitor to see if our controls are effective or not. And if they're not, we go back to what we're doing and going, okay, what wasn't working? How do we do it again? And then monitor and keep reviewing and improving. So taking that scientific approach and applying it within your organization, rather than just purely relying on evidence that was taken maybe out of context or from something that didn't have relevance to your context.
Yeah, I think sometimes the organization where they need the help is in identifying what the appropriate outcomes are, and what things to measure, because one of the elements, especially from a gendered lens, is there are some organizations that just use EAP data to measure the effectiveness of prevention programs. And EAP data is a very poor proxy, for that, especially for men, because men don't use EAP. I think the data I saw that men use EAP about half the time, or half as much as women do, is what I want to say. And women, I think, only use it maybe 27% of the time or something like that. So the data I saw were not very promising.
Yeah, I actually saw some data just in the past week from counseling phone, I can't remember which organization it was, but it was about that. I did note that women seem to be calling these helplines probably twice as frequently as what men did. And so, like you say, you're going to get a skewed view of what are the main issues, unless they're separating out male and female issues, which they don't typically do. It's generally all clustered into one bucket. And generally, the utilization rate for these services is very low anyway. We're talking about maybe 1 in 20 people actually using them. Yeah. It's reactive. It's not preventative.
And then do the people on the other end of that phone, do they know how to cope or deal with male callers? The Kids Health Phone in Canada is a distress call line, for kids and teens, and they said that the majority of the people who call were women. But when they actually trained up and developed a separate call line for boys, they started getting tons. But they actually had to train their staff, how to work more effectively with boys, because it was a different skill set, than it was working with girls.
Yeah, and even just the language, I think that boys and men use rather than compared to women, had a really interesting conversation, which led to a change in one of our wellbeing check-in tools with a school psychologist who was at an all-boys school, and she said, "Oh, the boys often don't, say they're upset or stressed; they say they're angry." Yeah. And so what we did was actually implement an angry mood or emoji, if you like, into our wellbeing check-in for specifically to target boys, and kind of had it ranked at the same level as, if someone was to say they were stressed. So stressed or angry, kind of interchangeable. They're obviously having a negative impact on their mood or wellbeing. But yeah, just to make sure that it was kind of something that men could associate with more readily, if you like.
Funnily enough, anger is the emotion that men and boys get rewarded for the most. So in other words, if they display a lot of other types of emotions, they can be shamed for that. But if they display anger, everybody seems to be okay with that. And
like on the sporting field, get fired up, you know.
Exactly. Whereas ironically, women are punished for displaying anger, especially in the workplace.
Oh, Joelle, you'd be stuffed. Like, she's always angry at me.
The key, Don, is to take it further, so people are too afraid to approach you about your anger issues.
I hear you.
Well, we've kind of actually touched on this individual level interventions versus systemic interventions. Obviously, you said only 1 out of the 15 funded projects focus more on organizational change rather than individual level. What are some ways maybe that researchers may be able to start building in more systemic or organizational level interventions, do you think?
Well, I think this is tough because there is a belief within the health promotion field that you have to dumb down your intervention program to work with an organization. In other words, that an organization doesn't want your health promotion program; they want a fraction of it instead. They don't want the whole thing. Just you proposing an hour intervention, they only want 15 minutes because everybody's time is precious. But that's not really the case, because there are hundreds of studies out there where people have taken and they've done really good, strong RCTs in organizations. They've been able to work with organizations. So I think one of the biggest problems out there that has to be overcome is this belief that organizations are unwilling to actually implement a full program. And I think once you can kind of get over that, then maybe there might be ways of working with organizations to adjust and change their organizational structure. One of the studies that I reviewed in my burnout webinar last week was really interesting. It looked at interventions for reducing burnout in the workplace. And this one systematic review compared individual level strategies, in other words, CBT, increasing job skills, that kind of thing, versus organizational, changes. There was reducing, work time to something that's much more manageable, increasing, supervision, and, increasing job control. And what they found was that the individual interventions didn't work at all, whereas the interventions that actually did target the organization, they worked a lot. They worked fairly well. So that just goes to show that organizations are willing to change. But the thing is that I think researchers and intervention specialists, they can't go in with the attitude that the organizations won't do it. They have to go in with the organization that how do we get these organizations to do this in a way that is meaningful and robust, that leads to a meaningful and robust evaluation. And if one organization doesn't want to do it, then let's try another organization, and because it's that, or if the organization doesn't want to do it, they really don't care about their individuals, their individuals' well-being. They're just there to check the tick box, on the program. That sounds harsh, but I've been doing this for a while, and I think that's probably at least a fairly fair assessment.
Yeah, I'd say it's probably 50-50. There are some that are just ignorant and don't realize, and they've been marketed too well, and they're sold a flashy program that is claiming that will have an impact. And then the others probably, like you say, they just want to do something that's perceived as warm and fuzzy, and don't really care whether it works or not. Kind of like the whole CISM thing, like you mentioned, like even though it was suggested this has no effect, you get these people putting out position papers saying, no, it's still better than nothing.
And I see organizations that are, kind of still, adopting and, the CISM model. And I keep wanting to, I unfortunately, I don't have any hair left to pull, but I pull out my hair, just in frustration. It's just kind of like, are these people being marketed to, or do they not know the literature? Or is it just because a lot of the literature has been, maybe not systematically put together, until just recently? So, yeah,
it's interesting what you pulled out from that burnout lecture that you gave the other day. I know we talked to Tony LaMontagne about his 2007 article, which was a systematic review of workplace mental health interventions from 1990 to 2005.
Yeah.
And he came up with the same conclusions back then. We did prompt him saying, hey, you're due for your next 15-year systematic review. Apparently he's got no time for that. So
yeah. Well, there was actually a really good one by Van Hove in, I think, 2016 that did a good job. They kind of built on, on that original, thing. But yeah, no, Tony's work, especially, the work, that he was doing with his colleague on suicide prevention programs in the workplace. Yeah, he's a powerhouse, that's for sure.
Yeah.
So something that I wanted to ask you about, I've noticed workplace initiatives that are being called preventative, but they're really actually early intervention.
Yep.
Can you maybe for our listeners explain what the difference is between those two types of interventions?
Okay. Preventative programs are usually put in place in a general workplace setting in a manner. The goal is to prevent the onset of poor mental health symptoms. But early intervention is usually applied in workplaces that are usually experience a lot of workplace trauma or trauma exposure in the workplace. Ambulance workers, firefighters, police, search and rescue individuals, those kinds of people, military. And the goal there is to prevent the onset of PTSD or depression, anxiety symptoms after exposure to trauma. So the prevention is more generic. The early intervention is more specifically tied to trauma exposure. Although, funnily enough, I've talked to a colleague, and in fact, I even wrote this, in my report, my scoping review, and that is that when you're dealing with first responders and military personnel, oftentimes there's no distinction between prevention and early intervention unless you get them and unless you teach them the prevention programming in basic training, in the training elements of the program, because first responders are exposed to so many potentially traumatic situations. Carlton et al. In Canada did a national survey of over 6,000 first responders in Canada, and they've been publishing a number of reports, on that since 2018. And I think I did the math for in my scoping review, and I think that the number of potentially traumatic events that individual first responders might experience within, I think, 5 years of joining, their occupation is in the hundreds. So, because they report approximately 11 or more than 11 a year. So over 10 years, that would be over 120 or so. So, and that was because that was the cutoff. The cutoff was 11 plus, on the questionnaire. So they didn't actually state how many. They just stated, so it could be 11, it could be 15, it could be 20. We don't know. But there is the notion of multiple, trauma exposure, and it starts pretty much from day one, on the job for a lot of first responders. So especially ambulance personnel, and so. Is there actual true prevention programming for first responder personnel? But there probably is more it's more of an accurate. You probably don't do early intervention in the non-first responder workplace. You do mostly prevention, training program. Although I think we may need to actually build in the early intervention work more broadly. For example, there's vicarious trauma experienced by court reporters, for example, and from communications personnel. Who take 911 calls in Canada. I don't know what the 3-digit number in Australia is. It 999 or 000? 000. And I remember, just in an anecdote, I was Canada introduced a third location decompression process for people coming back from Afghanistan on deployment in the mid-aughts. And they came through Cyprus, and they had a 5-day decompression process before they got home. And I was doing some research with some colleagues evaluating what people thought of that. It really wasn't effectiveness, is what do they think of it? And I was overseeing an interview that was being done by my contractors, my main contractor was a former general, so he knew the context. And we were interviewing what was called a forward, I can't remember the exact name of the job description, but this is the person who was on the radio to the forward, people in the field. They were calling in airstrikes because they were under attack. These people heard everything that went on at the other end of that call, and they were traumatized by it. They never left the base. They never saw any combat, but they heard it, and the level of trauma, and vicarious trauma, in them, can be quite high. So that's just an example of vicarious trauma, how we need to maybe broaden out the early intervention, focus maybe to a broader number of occupations.
Mm. I think like outside of the first responder space as well, I see sort of the mental health first aid often pitched as a preventative approach, but it really is an early intervention approach there as well. It's, identifying signs and symptoms in your colleagues and approaching them and referring them.
But there are 2 systematic reviews of mental health first aid, and they do not improve the mental health of the people who are giving it or the people who is being given to. So to what extent it improves the confidence of the people giving the mental health first aid to talk about mental health first aid. So I guess it gets to that question around, are you okay? It's like you can ask it, but are you comfortable dealing with what comes next if the answer is no? And mental health first aid does give people that confidence, but it doesn't have any impact on the mental health of the people giving it or the people it's being addressed to. So if it is a form of either prevention or early intervention, the evidence right now is suggesting it's not all that effective.
Yeah. Well,
and same,
sorry, Don.
Go ahead. I was going to say, same with programs that are designed around stigma reduction. So a lot of mental health programs are designed to reduce the stigma of mental health that's directed towards the self. So mental health self-stigma. The goal is that, or the assumption is, that if you reduce mental health self-stigma, then you'll increase the likelihood that somebody will seek treatment when they are experiencing mental health problems. But that's built on the assumption that there's actually a relationship between mental health self-stigma and treatment seeking in the first place, but there isn't. There is a small correlation between mental health self-stigma and intentions to seek treatment, but there's a zero correlation between mental health self-stigma and actual treatment-seeking behavior. So sometimes you have to be very careful about, the program that you're putting in place to make sure that it is built on a firm assumption rather than a perceived assumption.
Yeah, really interesting. One thing you were mentioning there before, Don, is with defense personnel, first responders, trauma is kind of built into the job. And so people go into those jobs expecting it. But is there any way then that we can actually prevent trauma, or that, the mental health outcomes associated with that exposure to trauma?
I don't think you can prevent the trauma per se, but I think what you can do is, because you're not going to be able to prevent the exposure.
Yeah.
The exposure is what is elementary to to the trauma. So you can't prevent the exposure, but what you can do is you can help downstream. So you can introduce, perhaps, like there are some programs out there where people can you can go to talk. It's kind of like a buddy system, where you can talk to people about mental health. They've got a little bit of mental health kind of first aid, but it's not quite mental health first aid training. And they can advise you on who to. In other words, they're a conduit to get you into treatment, and so that helps. So if you can provide some kind of way to ease, the people who are experiencing problems into getting help, then that's always sort of a good way to go. The other thing that you can do is you can find some way to kind of educate them around the notion that mental health is not a category. It's not a categorical distinction. I either have it or I don't. That is a continuum, and to recognize the symptoms, along the continuum. The one element of the road to mental readiness that I really do like, and a lot of people have liked, has been adopted by a number of different organizations, is the mental health continuum model. which I think the Canadian Armed Forces borrowed from the U.S. I think it was from the Marines. And so what you end up doing is you end up highlighting what it feels like to be green, yellow, I think it was green, yellow, then a light red, then a dark red, kind of thing. So as you go from that green is good, to red is bad, red stop. And if you can teach people about that. But one of the other things I heard is, when I was talking to my subject matter experts for my report, is that when people are experiencing problems, there often aren't enough mental health professionals to go around. There isn't easy access to them. And for those who are in serious trouble, there aren't any beds available, for them within the medical system, or they're very difficult to find. So I think there are multiple, knowing that people are going to be experiencing, or some are going to be experiencing, some adverse symptoms. Not all people experience PTSD who are exposed to trauma. Only some do. And if you do, get help. How do we get you into help as fast as possible? How do we break down some of the stigma? Although I know that's not that's not linked to treatment seeking on your own, but you may be able to be pushed into it a little bit more, or prodded, helped, by peers, and then making sure there's actual support. A lot of my clinicians basically say, we keep talking about getting people into a good mental health, into a mental health, into an office, where they can talk to a mental health professional. But there aren't enough mental health professionals out there, and so who controls that, and why?
Mm.
Right. Yeah.
Yeah, no, it's a difficult topic, as you suggest, to given the inherent trauma that people are going to be exposed to. How do you actually prevent the adverse reactions and taking into account individual differences, I guess?
Yeah. I think one of the big things is just letting people know that just because you are exposed to a trauma doesn't mean you're going to get PTSD. There are some people out there touting the notion that, oh, you're an ambulance, paramedic, you will get PTSD, and that's not the case. But then there's the other notion out there that, I'm resilient, like I'm strong. This is kind of a male thing as well. I'm tough. The whole notion of male stoicism, I can deal with whatever crap you pull, at me. And then, it's like then not quite realizing, when the mask you're wearing is exhausting you. Like, Zach Seidler, did a wonderful systematic review of masculinity and depression. And he showed that, men really won't seek treatment until every other resource that they have at their disposal is exhausted. So, and they themselves are emotionally and physically exhausted.
Mm.
So, yeah.
So we've talked a lot about different elements of sort of mental health initiatives or strategies in the workplace. Do you have a view on what you feel is missing at the moment, in particular from a prevention perspective in the workplace?
What is missing? My biggest issue in terms of what I'm thinking about is really gets back to some of the main observations I made in my report. An overemphasis on the individual, less focus on the organizational causes. We know we've got decades of research, longitudinal research, that show that these organizational factors cause poor mental health in workers. Yet there's not really doing very much, about any of that. So let's stop blaming, because in essence, so that's what this does. This puts the burden. It blames the worker for things that are out of their control. They don't control the level of job demand. They don't control the level of control they have over how they do their job or the support they get. So you have to stop blaming the individual for for their poor mental health. I posted something on LinkedIn recently. It was a journal piece, not a scientific article, but it was basically saying that when organizations implement burnout interventions, it doesn't lead to better or reduced burnout. It leads to anger and cynicism within the staff because they see it as a token implementation. So, yeah. Stop focusing on the individual. Stop if you're for first responder and military veterans. Stop focusing solely on on PTSD as the main interest, and uh, evaluate your findings in a robust manner. Use a gendered lens. I know we didn't mention fidelity, but you have to implement fidelity across any intervention program. I've seen programs where the instructors they kind of go way off book. And there was a study that looked at fidelity in the Road to Mental Readiness program in recruits in Canada, military recruits. And the author, Denise Ficcartolo, found that sessions where there were no fidelity checks actually had negative outcomes for the students taking. In other words, the negative outcome there was they left basic training at a higher rate. Now, did they flunk out? Did they decide to leave? We don't know. Did the instructors scare them? We don't know. But they definitely weren't building any sense of positive mental health. Or maybe they were by saying, this isn't for me, I'm leaving. I don't know. But fidelity check was a big issue. And there's a lot of fidelity checks are not very popular in program implementation or program development or program implementation. And we really need to make sure that these are manualized programs. They need to be given the same way so that they can generalize across different organizations.
Mm. So to follow on from that, what advice would you give to organizations who are wanting to improve their approach to psychological health and safety management?
Oh, the biggest one is don't buy the marketing, buy the science. And if you don't know how to buy the science, if you don't understand the science, spend some money to bring in an advisor who can do that work for you. And I guess the other thing is, it's most likely the organizational factors that are the biggest culprit. So be willing to find new ways to work in your organization. The assumption that this is the way we've always done it is not a good excuse for how we move forward, because we've known for decades that these are causal factors in poor worker mental health. We know this. So let's find ways to change the program. Like I sit back and I was thinking recently, thinking back to Dickens, 7-day work weeks or 6-day work weeks, 12 to 14 hours a day, for minimum wage. We're now down to, for a lot of people, 5 days, a week, 40 hours a week. Some people, take extra pride in working, more, but even in those organizations, like in Canada, doctors no longer are allowed to work, more than a certain set number of hours, because of mistakes, and that has an impact on both patient, but also the doctors themselves. So let's start changing the workplace for everybody else as well. And let's start treating mental health as the same way we treat, physical safety in the workplace.
Yeah, no, there's some really good thoughts. Actually, while we're on
cohesive at all, but
while we're on those thoughts, we asked the same question of all the guests on the podcast, putting on your looking into the future, looking into your crystal ball. What are your hopes for the future of workplace mental health?
I think my biggest hope is that organizations get the message that the problems are not in the employees, the problems are in the organization. I think if we can get away from programs that are employee-centric to programs that are organization-centric, and try and redo the way work is done, I think we'd be, that for me is, I think, if we can get more and more organizations doing that, then I think that that would be an excellent, first step. But I don't know how or when. Maybe now, if, like in this day and age with the quote unquote, the great, what they call the great resignation, that's, or whatever it is, it's supposed to be happening. I know there are a number of people out there who they now kind of see the light, and they're finding alternate ways of making an income without having to work within a setting or a context or a workplace that is in essence harming their mental health. And there are a bit more, there are a lot more people who are aware of that. And I think who are trying to find ways to find alternate methods of working. And so organizations may be forced into change, or they may want to, take the lead and do it themselves. Either way, my goal is really, to improve the mental health of all workers that are out there, no matter what their occupation, whether it's the barista serving me my coffee, or the ambulance driver who is picking me up to take me to the hospital when I'm sick.
Yeah. Now, I think that's you've just summed up beautifully why we wanted you on the podcast, Don. We're very much around, the shared responsibility for workplace mental health, but the piece that's missing is the employer's responsibility more often than not. And so we really do hope that, what you envisage comes true, and hopefully that the three of us and other colleagues who are working in the industry can all have that impact and direct companies in the right way.
I would hope so. I got my fingers crossed, but I have to admit, working in this field has kind of made me a little bit of a pessimist, but I'm happy to be proven wrong.
Yeah, well, you're dealing with at least one violent optimist in the room, so we'll get there, Don.
But that's him, not me. Do you have some words of advice for our listeners who want to work in the field of psych health and safety?
Oh, well, my background is in psychology. So the area that I think is probably most relevant from my background is what's called occupational health psychology. And it's a growing field. There's a large number of people doing occupational health psych in North America and in Europe. I don't know too much about the occupational health psych field in Australia, though. And but I think that those who are interested in working in that area from the psychological focus, that's kind of the area that I think has the most direct implication or the most direct effect. You'll teach people, basically everything they need to know about improving, psychological health and safety in the workplace. But there are other avenues for that. So unfortunately, I don't really know too much about the training of people who work in HR or in occupational health in general, to know. But a background in occupational health psychology will give everybody a good training in both methods, but also measurement, especially in the mental health field. Because what I find is that measurement is one of the key elements, especially outcome measurement and mental health measurement. So you need a firm understanding of how measures are developed and validated. And that's often a weakness, I find, in some respects. People are more likely to want to create their own outcome measure as opposed to using a validated measure. So anyway.
Wonderful. Good advice. Thank you.
Well, Don, it's been a fascinating and probably, like Joelle mentioned earlier, a bit of a geek out, nerd out with you. I think the timing of this is probably going to be similar to Tony Lamontagne's, one of our longer episodes, but really well worth it given the depth that we're able to go to into the topic.
Well, I've enjoyed it, and hopefully everybody else will. Sometimes I can get on a high horse and sound kind of preachy. Hopefully that didn't happen here. So
it didn't sound preachy, and if you were preaching, you're probably preaching to the converted if they're listening to our podcast anyway. So there would have been some hallelujahs coming from people's cars as they're commuting to and from work. So but thank you so much, Don, and
my pleasure.
We look forward to keeping in touch with you over LinkedIn.
Yes, definitely. Please do. I always enjoy chatting with both of you.
Yeah. So that brings us to the end of the episode, listeners. Don't forget you can watch the YouTube video if you'd like to do that on the Flourish DX YouTube page. And we'll definitely be pulling out a couple of clips from this as well to share on the Flourish DX LinkedIn page. While you're over on LinkedIn, you will see Don, myself, Joelle there quite a bit. Feel free to engage and connect with us if you want to continue the conversation on that medium. So thanks a lot again, listeners. We'll catch you next episode.